Right now, your lungs are still moving, but they are losing the war. Air is going in, air is coming out, and yet your blood is returning from your chest too dark, too acidic, too starved to keep the rest of you alive. Your brain, your heart, your kidneys are all about to learn the same brutal truth at once. Breathing is not the same as oxygenation. This is a science breakdown, not medical instruction. Subscribe to Dark Truth for extreme body science under real-time pressure. Inside healthy lungs, millions of tiny air sacs called alveoli pass oxygen into the blood and pull carbon dioxide back out. But when severe lung failure hits, that exchange begins to collapse. It can happen in acute respiratory distress syndrome, severe pneumonia, major inhalation injury, drowning, or other critical lung damage. The alveoli can fill with fluid. Inflammation can thicken the barrier that gas is supposed to cross, and every breath starts doing less than it should. At first, the body fights back quietly. You breathe faster. Your heart speeds up. Stress hormones rise. Blood vessels tighten where they can. Your brain pushes harder, trying to drag in more oxygen and dump more carbon dioxide. But if the lungs are badly damaged, effort stops mattering. You can be pulling in air and still failing. That is the nightmare. From the outside, it looks like breathing. On the inside, the delivery system is breaking apart. And once oxygen levels fall far enough, the problem is no longer that the lungs feel bad. It becomes full-body chemistry. Cells begin slipping toward emergency metabolism. Acid starts building. The heart has to work harder in a body that is getting less support by the minute. The brain becomes vulnerable to confusion, agitation, then collapse. The kidneys do not negotiate with low oxygen for long. If this spiral keeps going, one failing organ starts pulling the others with it. So why not just turn the ventilator higher and force more air in? Because the crisis is usually happening on two fronts at once. Oxygen may be too low, but carbon dioxide may also be climbing. That means the blood is not just under-oxygenated. It may also be turning more acidic as carbon dioxide accumulates faster than the lungs can clear it. Now, the body is fighting on two fronts. Not enough oxygen coming in, and not enough waste gas getting out. That combination can push a failing body into panic, exhaustion, and organ stress fast. And damaged lungs are not empty balloons. In severe respiratory failure, parts of the lung can become stiff, flooded, inflamed, and dangerously easy to injure. A ventilator can be life-saving, but high pressures and high oxygen levels also have limits. Push too hard, and the machine that is buying time can add more stress to tissue that is already barely holding together. This is where the decision gets darker. If even the ventilator cannot keep enough oxygen moving into the blood or enough carbon dioxide moving out, the rescue has to leave the chest. That rescue is ECMO, extracorporeal membrane oxygenation. The name sounds clinical. What it really means is this. Blood leaves your body. A machine acts like an artificial lung, and the blood goes back in with oxygen added and carbon dioxide removed. Not forever. Not as a cure. As a desperate bridge. A way to keep your organs alive while your real lungs are too damaged to do their job. And this is the part that feels like science fiction. Your blood is pulled from your veins, routed through a plastic box that strips out carbon dioxide and loads oxygen back in, then pumped into you again before your organs run out of time. For a few critical days, survival may depend on a machine doing the chemistry your lungs no longer can. That is the dark truth of ECMO. You are alive, but part of your life support is now happening outside your body. And the machine lets you see that battle in color. The blood leaving your body is darker, a deeper red edging toward maroon, because it is carrying less oxygen and more carbon dioxide. The blood returning from the circuit is brighter, vividly oxygenated. The color shift almost unnatural in how obvious it looks. Dark out, bright back in. One line carrying the chemistry of suffocation, the other carrying time bought back by a machine. If the lungs are the main problem, the setup is often designed so the machine mainly takes over oxygenation and carbon dioxide removal, while the heart still does most of the pumping. That means the goal is not to fix breathing in one dramatic moment. The goal is to stop the chemistry of suffocation from winning long enough for the lungs to rest, and rest matters more than people think. Once ECMO is carrying part of that burden, the ventilator can often be turned down to gentler settings. Lower pressure, less strain, less risk of adding more injury to fragile lung tissue. That is the twist. One of the most aggressive machines in intensive care is sometimes used so the lungs can finally be treated more softly. But the body is not safe yet. The moment blood starts moving through plastic tubing outside the body, a new danger appears. Blood is supposed to travel through blood vessels, not artificial circuits and membranes. It reacts. Contact with foreign surfaces can activate clotting and inflammation, and clots inside an ECMO circuit can be catastrophic. A clot can damage the circuit, block flow, or break loose and become a threat somewhere else. So blood-thinning medicine is often needed. Now, survival depends on a vicious balance. Too little anticoagulation and clot risk rises. Too much and bleeding risk rises. Every hour on ECMO is a gamble. The team is constantly trying to stay ahead of two opposite disasters. Lean too far one way, and a clot can threaten the circuit, the lungs, or the brain. Lean too far the other, and bleeding can turn from manageable to life-threatening. It is not a calm middle ground. It is a narrow moving line that has to be watched again and again because the body, the disease, and the circuit are all changing at the same time. And the machine brings its own hazards. Tubes can shift. Blood flow can become harder to manage. The brain still has to be protected. The kidneys still have to keep up. Infection can still arrive. Circulation to a limb can be threatened in some cases depending on how support is configured. Even with oxygen improving, the rest of the body may still be fighting inflammation, shock, infection, or the original injury that destroyed normal lung function in the first place. Here is where it gets worse. Better oxygen numbers do not mean the crisis is over. Oxygen arriving later is still later. Some organs may already be injured from the time spent starving. The lungs may still be swollen and inflamed. The disease that triggered the collapse may still be active in the background. ECMO can buy time, but it cannot erase the damage that happened before the rescue began. And what does the body feel during all this? That depends on the patient and the situation. Some people on ECMO are deeply sedated, especially early, because severe respiratory failure itself is terrifying and exhausting, and because other life support measures may still be needed. Some patients in selected situations can be more awake later on. But whether awareness is present or not, the physiology is the real drama. Blood gases begin to shift. Acid-base balance may improve. Oxygen delivery to organs can recover. The body may finally spend less energy on raw survival and more on repair. If you were watching only the chest, you might miss the true story. ECMO is not really about lungs rising and falling. It is about whether enough oxygen reaches tissue and whether carbon dioxide is leaving fast enough to stop poisoning the chemistry of life. It is about perfusion, pH, pressure, organ survival. The chest is where the crisis begins. The bloodstream is where the verdict spreads. And this is the part most people never think about. ECMO does not heal lungs by itself. It protects the rest of you while the lungs try to heal, while doctors treat the cause. And while time decides whether the damage is reversible, the machine can take over gas exchange. It cannot guarantee recovery. It cannot promise memory will be untouched, strength will return quickly, or every organ will walk away unharmed. Let me know in the comments which sounds more terrifying to you. Watching your blood leave dark and come back bright red through a machine, or knowing that every hour on ECMO is a balance between clotting and bleeding. There is another hard truth. Recovery from ECMO is not the same as going back to normal. If the lungs heal enough, the machine can be weaned away and removed. If they do not, the path can lead toward prolonged critical illness, long rehabilitation, or in some cases, transplant evaluation. Some people survive but face weakness, confusion, memory gaps, or the long shadow that follows any severe ICU stay. Saving a life and restoring a life are not always the same job. So when people say ECMO keeps you alive when your lungs fail, that is true, but incomplete. ECMO does not replace life. It protects life from running out while the body tries to recover. It is a temporary external detour for the most essential exchange your lungs are supposed to perform every second you exist. Because in the end, lung failure is not just about air. It is about time. How long your organs can survive the shortage. How long inflammation can keep flooding the alveoli. How long the heart can push against a body turning more acidic and more desperate. ECMO steps in when that countdown is getting too short and turns a collapsing oxygen line into one more chance. Sometimes that chance is enough. Sometimes it is not. But when your lungs can no longer move oxygen into the blood that keeps your brain awake, your heart beating, and your cells alive, ECMO is the machine that tries to hold the border. Tap subscribe for more body disaster science and watch the next Dark Truth video to see what happens when another vital system fails and medicine has only minutes to take over.